Right, done. We're all right. We're there. We're there. Anyway, has everybody had a chance to read about Jack and his, Lisa sort of summarised his lifestyle quite well.
Luckily, before we started recording, Chris.
Yeah. That is fine. I think anyway, let's just carry on because otherwise I might get silly. Okay, so what do we know about this man? He spends a lot of time seated, driving around, and it looks like he enjoys his job. Would you say that? I get a sense of a man who enjoys his job.
I think there are certainly an assumption that we have to make, which is it doesn't say whether he's doing any other exercise outside of, around the golf.
Sure. It sounds like he's pretty busy to me. He looks a pretty busy guy, and he looks like he's playing golf. But around that, his lifestyle. You are? Sorry, Mark.
Should we assume that it's either golf or nothing?
That's a reasonable.
I think so.
That's a reasonable goal. That's a reasonable kind of guess. So he went away and spent a bit of time with his twin daughters. I like the people who write this. It's brilliant. And, karate tournaments, very important to be there. And then he thought, I feel a bit bad. So he decided to book a 3-day weekend and get as much golf as he possibly could. But unfortunately, he pulled something. That's not good, is it? Bless him. In his lower back. Yeah. And he struggled to get out of bed on Monday morning. And he's still in severe pain on Tuesday. He had an X-ray examination, ruled out any serious pathologies, so no major kind of dysfunction. We're going to make that assumption. I think we're going to work on that. So this is a soft tissue work, so that falls into our category beautifully. This is what we do. So he's not struggled to get it yet. So his doctor suggested some counter pain relief from physical therapy. And yeah, so what do you think? It showed a few postural abnormalities, including increased lumbar lordosis. Are we all happy with what a lumbar lordosis is?
No idea.
Sue is shaking her head.
I'm not a sports massage therapist. No idea. What does that look like?
What's that look like? Okay, I'm going to see if I can do this. I'm going to do a bit of this and a bit of this. And here's our man. Yeah, familiar kind of stuff. Yeah. And if I see everybody see that, okay? So I'm going to just drop that in. And
he's lost a lot of weight. That's my first observation. He lost a hell of a lot of weight since the last saw.
Jack is not in good shape, is he? No. I've missed your humour, Lisa. I do. Every time I see you, I re-engage with your lovely kind of joy of fun, and I think I really miss you. So, okay, so lower back lordosis would be. Let me just, if I can do really, I might surprise myself and be really tricky. So if I open that and fiddle around with that, so lordosis would be the curve in this lower back here. All right, you got that, Sue?
Yeah.
So you would have a situation potentially where his pelvis, if we rock our pelvises forward, so the place between.
Yeah.
So the space between here and here, and the line between here. Oops. Sorry. I'm not good at this, am I? Let me just undo that. Oh, no. Oh, yeah, that's it. So the line between here and here, yeah. Mm-hmm. If his pelvis rocked in this way, yeah, so his pelvis rolled down at the front. So this bit here came down.
Yeah.
And this bit here went up. there would be an increased curve here.
Yeah.
Yeah?
Yeah.
Okay, so that's lordosis, that curvature of our lower back.
Okay.
All right. And it's very common for people who sit a lot. And we'll unpack it a bit more as we go, but I thought I'd just drop that in just as we come back to that drawing in a minute. Okay, so he's got an increased lumbar lordosis, increasing abnormal, what's an abdominal mass? Do you think
Does
that's
that just mean you've put on weight?
Yeah, I don't know. I mean, it's an interesting description, an abdominal mass. I think there tends to be, when we roll forward with our pelvis, our abdominal, there would be a kind of sagging and a loss of condition in our abdominal, the muscles down the front of our, between our chest plate and our pelvis. But yeah, it could be just a bit heavy. Lack of control, weakness of those abdominal muscles, giving a kind of a flabbiness, if you like, to his abdominals. Would you go along with that?
Yep.
And then the diagnosis of on an anterior pelvic tilt, which is what I drew there, Sue, of the front of the pelvis being lower and the back of the pelvis being higher, and getting that kind of tilting, rolling forward, is an anterior front rotation of the pelvis. All right, which is, and you measure that by measuring those bony landmarks in our pelvis. That's what goes on. A slight knee flexion while standing up. So, yeah, happy. So he bends his knees slightly. So you get that sense of him kind of.
I got a bit confused by that. Does that just mean he can't straighten his legs when he's standing?
Is that because the hip flexors are so tight that it's actually, he can't straighten his leg out properly, do we think, ish?
Could well be. Yeah, could well be. Yeah.
Because I thought either that or maybe it's something to do with the swing. I don't play golf, as you can tell. But maybe something to do with the swing and one of the knees coming in, or I don't know. Maybe.
Yeah. Interesting kind of sense of that, isn't it? It's like knee flexion. Stood up. Manual massage testing and flexibility assessments were hampered due to the fact that the guy was in a lot of pain and discomfort, and clear acutative activity of the injury. Gentle range of movement exercises gave Jack to try to, so as the first one is some heat, moist heat, and electrical stimulation to help pain. So something like a TENS machine or something like that, I guess, over that area to try and change the patterns that were giving the irritation to the lower brain. Hi, Sarah. Good evening to you. How you doing? We're just, I'm just in the process of reading through, Jack. Not got to any questions yet, just identifying lordosis and anterior tilt of the pelvis, how he's presenting, and got a feeling of a guy who sits down a lot, drives a lot, and that kind of ruling out any pathologies of any concern particularly, but classically that kind of anterior tilting pelvis, and just got as far as that really, and just started to sort of just paint the picture of Jack, really. That's what we got. Anybody want to sort of say anything about that, give a picture of that, or add any bits of that? What would our advice be around managing pain for this man? It's still, he couldn't get out of bed or struggled to get out of bed the first day. Pretty sore. I get a sense of somebody who's in quite a lot of pain here. That tweaking, that pain in his lower back, pulled something. Any guesses what that might be about? Or in terms of, I suppose we can easily get into the diagnosis and thinking about our treatment plan, but it's quite interesting because I think you get people who will phone up and say, look, I've just been playing golf, I've done this. This is the level of pain I'm in. Any thoughts, any advice? And people might phone 111, might they, get some over the phone advice. But I've had many phone calls over the years where my husband's just done this, or my wife's just done this, or my son's just done this. And it's really helpful, I think, to give some, if you like, on the phone first aid, for want of a better word. useful for us? What can we do? What can't we do? What's common sense? Just useful to tease it out, really. Have a think about it. I'll shut up now.
I think in the early days, if they're ringing up and they've just done it, it needs time to settle down. So if they're able to take sort of anti-inflammatories, sort of rest ice, that kind of stuff, I guess. But yeah, like in this example, obviously you'd advise them to get it checked out by somebody else first in case, he's done something, and it's anything other than sort of muscular. So, but I think I'd, allow a few days or a couple of days at least just for the initial sort of inflammation or whatever's going on to settle down a little bit, and then see, because if he's in so much pain and the muscles are so tight anyway, I think he's going to resist even more if you were trying to do some kind of manipulation, however gentle it would be. I think, that'd be my personal thought. Just a couple of days, 2-3 days at least. And then, give them some sort of gentle stretching exercises to do maybe after a couple of days and see how they're feeling and sort of ease into it a little bit, I think. And then when, if they can't even get out of bed properly, there's no way they're going to get to you and get on a couch. And I wouldn't be happy with treating them at that point. So once they're able to get to you, different story, really. They might still be in obviously some discomfort, but and if they've been checked out, at least you're not going to make anything worse.
I think it's interesting often to think through, why has this, okay, this has happened because he sits down all day and he decides to kind of have a bit of a busy weekend with his golf, he overdoes it, and the muscles say, sorry, we're not playing game, we're not prepared for that. You haven't prepared us for this activity, and here we are telling you to stop. So the first thing in my head is always about what's the body saying to you at the point, given that there's no, and maybe at this stage it's hard to tell whether there is actually some kind of pathology disc stuff going on. We've been told here not, but I think it's interesting just to stay with, this is the way the body says stop. And how do we increase that speed of recovery through medication, i.e. what you said, Sarah, anti-inflammatory stuff, or do we allow the body to do this itself? The current thinking around ice and heat, it's changed over the last few years, and that model of you damage yourself, you stick ice on as soon as possible. Is that actually stopping the body to do what it's meant to do and recover? And I think that's really interesting for us to sort of get an idea of, because people will phone up and say, look, I've stuck him in a hot bath because that's, I want the muscles to relax, or whatever, and I think it's helpful for us to really begin to start, what's actually happened here? Why have the muscles gone into this spasm, this tightness? This is a protective move, isn't it? This is the way the body says, sorry, you're going to have to stop. Anybody else got any thinking around icing? And
it makes sense, I think, doesn't it? Because I guess the body's way of healing itself, excuse me, is there's a certain amount of natural inflammation, isn't there, goes on in the initial stages. So yeah.
I think you need inflammation to start the natural healing process. My understanding of ice was it can help to modulate the pain. But then if it's muscular, I always thought with muscular, then maybe you should use heat. So, maybe you could let him try both ice and heat and see which one works for him. Or, I don't know whether you should stick with one or go with one first and then try the other.
Yeah, because I've got a friend of mine who can't take anti-inflammatories, so he can only use, heat and ice and sort of alternate, rest, ice, heat, whatever, and see which works best. So that's quite frustrating for him. So he's got no quick fix anyway. So
where are you in this, Sarah? Because you get people coming in with knackered calves and all the stuff that goes on in the running world. This is your forte, I would suggest.
Yeah, so I would well, talking about the pain levels that would obviously be acute at this stage, having ruled out he's been for an X-ray, so we haven't got any bulging discs causing this issue. It's just purely muscular. So we can accept that it's purely muscular, but what we have to also realise is that the muscles are in spasm. So unless you've got a magic wand to take them out of that spasm, which we haven't, that's the main concern. That's the main consideration for where you go with your treatment. And if you pop ice on that, you're going to shut down, apart from shutting down the nerve endings that are feeding the information back to the brain and firing up that protective system, which is really important. It's not necessarily about getting rid of that protective system and those spasms as quickly as possible. Sometimes you've got to let them do their job. And sometimes a combination of heat and ice is good. But until the spasm's gone, I would just keep the guy comfortable, like Lisa said, and make sure that those spasms, I mean, you can use trigger point therapy very gently on spasms. You can make a difference, but are you putting the patient or the client into more danger then? Because that spasm's there for a reason, and that's usually how I treat people at that really, really acute stage, is to get them to find a comfortable position and basically wait for that main spasm to dissipate a little bit. I wouldn't use ice at this stage, but I would suggest warmth, and I wouldn't suggest painkillers either, because again, you're switching off nerves that are supposed to be feeding information back to the brain. So you're numbing them virtually with painkillers at that stage.
So when you say warmth, Sarah, for sort of the initial 24 hours or 48 hours, or depending how quickly it settles down, or is there, like, I can't remember now, is there like a guidance, or depends what they've done, I guess. But
yeah, I mean, people will treat people in the first 24 hours, and when the pain's acute, and you can get round things like, I mean, for example, he wouldn't be able to lie flat on his tummy, so you could work on his back. You'd have to have him positioned, seated, or chances are he won't even get on the couch because he won't be able to go. So you can start to help those muscles relax a little bit, and there's all the other physiological things that go on when you give massage. It calms the person down, they feel like they're in good hands, and that's all important for what's going on inside them, and you're helping that along if you can get some hands on. Yes, I do think it's beneficial. Yeah.
No, thank you, sir.
But you know, it does depend on the person. I think in this situation, because it was done with rotation, it's going to be, because he rotated to make that shot, didn't he? I would say there's going to be tissue damage, quite deep, and those breaks are going to be on really, really firmly. Sorry, I can't think of the word now. The spasms are going to be on, full on, because of the nature of that injury. So my suggestion would be just get yourself comfortable where the spasms are not firing off, and just be there, sit there. If you can get a little bit of warmth on, or if you can even get someone to massage your shoulders for you, because like we said, there are other ways that you can start to feel relaxed and just let that go a little bit. You know, get your partner or your wife to just massage your shoulders for you and try and take the focus away from the back, and get you a little bit more relaxed. So yeah, I'd probably, in this particular case study, that's probably what I would do, right or wrong.
I don't think it is a right or wrong. I think no, I do think it's a right or wrong. Sorry, I don't think you can be necessarily wrong here. I think it's all about the individual. You know, this guy that we're looking at here, I probably agree with you, Sarah. I think I'm on your same page. I've had people who can't get out of bed, and it's not a question of getting out of bed slowly. They just laid there, and turning gives them excruciating pain, and they're in real agony, you know. And at that point, there is a place then where medication might help with that. And things like codeine, things like diazepam are designed to sort of take the spasm out and to give people the ability to be able to relax. But every case is different, isn't it? And I think knowing that we can sort of give some advice, but also it's really important that they have contact with other professionals, you know, that, you know, the measuring and the discomfort is a really tight one. Some people can't manage it at all. Other people will quite happily live with a bit of a spasm, and yeah, it's really, if I lay like this, it's fine, you know. So it's really interesting, isn't it, to give people that advice. And you believe me, you will get people phoning you asking your advice on this. So to have a series of kind of, let's look at this together. The customer needs to make their decision, but here are some different ways in which you might manage this. And where, you know, that acronym of RICE is a little bit old now, and needs to be rethought. That it's not just appropriate to whack ice on, certainly for the first 48 hours until the body is starting to heal itself. And yeah, food for thought.
What I usually say to people with a back injury like that in the sort of first 24 to 48 hours is to get them to, whenever they move to get up out of something, so off the chair, off the loo, out of bed, is to have that engage the core like you're resisting a punch to the stomach. So a real like that, and then you take the pressure off the back, you can stand up, and then you can let your breath out. So it's not about holding your breath all the time or having your core wrenched all the time, but it really helps with just getting around in those first few hours, first few days.
Thank you. That's really helpful. Yeah, good. Okay, so then that crunch question of how long is it before we see them? You know, they will say, look, I can book in to see you tomorrow. Would you leave this a week or so? I mean, textbook, 5 to 7 days for an inflammation to get to a place where soft tissue can go on. But, you know, as Sarah said, I think working around the location, looking at other groups of muscles that support that area, really interesting. What do you think, Mark? Where are you in that kind of put people on the spot a bit?
If seems a little bit too cute to be doing too much soft tissue work, I mean, I'd probably go along with that 5 to 7 days. Certainly, he's a bit more comfortable getting on and, you know, being able to get on and off the couch.
Yeah. There would be an element of history here. Is this a one-off thing? Is this just the first time it's ever happened to him? Or is this oh yeah, this is familiar for me. There's a whole load of scar tissue involved. This is a same side, same situation. Every now and again, if I overdo it, this comes back. You know, so this is a chronic rumbling problem, or something that has just happened because he's misjudged, you know, and this activity and the timing, and he was dehydrated, and all the other bits that might feed into this particular scenario. I mean, that's important separation for me. Is this a one-off, or is this kind of, oh yeah, a familiar story for him?
I think if it's the first time it's happened, it'll be the first of many, put it that way, but I think it's more, it was the straw that broke the camel's back, looking at his history and his lifestyle, and the fact that for the last month he hasn't played golf and he has been driving a lot, and we all know that the driving posture is not great for, you know, if you've been sat in that position for a long time, your back is in a stabilizing position rather than a working for you, and then suddenly after a month, you go and have 3 days worth of golf, which is sublime to the ridiculous, isn't it? So I'd say it was the straw that broke the camel's back, and will probably be a weakness for him for some time.
Yeah. Who wants to play golf anyway? I mean, isn't golf a fairly sort of daft game? Probably.
You can have very good hand-eye coordination. I know that I tried it once, many moons ago. Not a chance. So people were queuing up behind us because we couldn't. It's only a 9-hole thing. I couldn't hit the thing. It's terrible. It's just embarrassing.
I'll ignore my stupid comments. Right. Okay. So should we move on? And is it coincidental that Jack has hurt his back after a month away from playing golf? Explain our reasoning. I think Sarah's just done that, has she? I mean,
yeah.
Yeah, so definitely not a surprise.
It's not a surprise, is it? What makes you say it's the first of many, Sarah? What's your thinking about that? You're going to see this man on a regular basis, do you think? Or
well, we know that he's got anterior tilt and lordosis, and that will be, some of that will be a result of the fact that he drives around a lot. That's his job. That's not going to change in the future. He's a sales rep, and I know that these people pop in and out of surgeries for 5 or 10 minutes, and then they're back in the car again, and they can cover quite long distances. So I would say his posture has been waiting for something, you know, his back's been waiting to go for a while because of this long-term posture that he has. The lumbar spine will be lordotic, the discs will be under pressure. So if it hadn't been the muscles, it may have been the discs in time to come, but something was going to. The other reason why I said that, though, was because he hadn't played golf for over a month, so he had changed his pattern from being a weekend warrior golfer to not playing golf at all, and then suddenly taking on 3 days of it, which again is sort of, you know, sublime to ridiculous, isn't it? So that's why I'm saying I'm not surprised it went. And it was, and the deepness of the depth of the injury, if he's gone right through to sort of, we all know the layers on the back. You've got your lats, you've got QL, you've got multifidi, and then you've got all the intermuscles between the spine. If he's gone right deep, this won't heal quickly, and it will need work to get back to the same level of strength, as in workouts or exercises regularly, to get back to the same level of power to be able to whack that ball like he used to. That's why I say that.
Yeah, no, I'm with you. But shall I just screen share some of the muscles that we're talking about here? Is that helpful? I think it always is to remind ourselves of some of the anatomy. So I'll just come back to my little drawing of my my chappie. See if I can make that a bit bigger for people, and I will. So, oh, sorry. What I'll do here is just I'll just put the layers on, and then we can see some of them working, and just help us to get our head round these lower back, and you know, just remind ourselves these bony bits on the outside, transverse processes of the lumbar here, those lower vertebra, and then on the side, on the center, the spinous processes. And then all those lovely deep muscles that sit, you know, really sitting between each vertebra to give us this amazing network of strength. And if I just, these multifidats, which is right down into that gully between the spinous processes and the transverse processes, if I do a bit of rotation, you can see just how these muscles kind of use to rotate our bodies as we turn backwards and forwards. Yeah, that deep, I think that's what you're talking about, Sarah, isn't it? That right down between, I know, okay, here we are, sort of 3-4 layers down. Yeah, deep stuff. And then, of course, we build up a bit more and we put the next layer on. And these deeper, what are described as the thoracic spinous process. No, what are they called? Huh, get your words together, Mr. P. Erector spinae. Erector spinae group. I think what's so important about these fellas is that they run right the way down. You can see they run down. Here's our PSI, these bony lumps here. Cheek of our, gap in our bottom here. Right down to almost our coccyx. Long flat tendons sitting over the SI joint, really kind of sitting deep inside here, and then connecting all to the ribs as they come through. And again, the rotation movement of these giving us that flexion. And that side flexion. And I think the bit for me is to realize that these run right down from base here, crease of the bottom, right up to above onto the first, second rib. So they run right the way through, and these different groups of muscles here, really, really significant. And as always, chasing the pain is a must, or we fall into that trap. So this could well easily be where he's hurt his back, lower lumbar area, and that kind of pain pattern that comes all the way through here, pain in his glutes, trigger point work all the way up his erector spinae. And then obviously then we can pop another layer on. Deeper, another longissimus, iliocostalis sits right next to that. So you've got a real fanning of deep muscles spanning almost half the ribs. We tend to think the erector spinae is near that, just in here, but they fire, halfway almost, certainly a third of the ribs across. Really, really important to remember. Then we have that build of the abdominal obliques coming through, and again, all part of that rotation. The deep serratus posterior, serratus anterior, real breathing, stabilizing muscles, all get spasmed, all get into this tight sort of protective mode of muscles coming together. And then we come to our top layer, which is our lats. So we're looking at good, 2 to 3 or 4 layers down where the damage is done, if you like. Just useful to remind ourselves, isn't it? Just to see some of that group. And the key bits for me are that the spinae group run all the way down from the neck and compensate for all the other deeper damage. So as a therapist, palpating the structures in Jack's lower back, what do we expect we may find? How do you adopt your palpation techniques in relation to the pain he is feeling?
I expect him to be in quite a lot of pain. What
are you trying to find? What's the purpose? I mean, of that? What are we being asked to look at?
I think basically because
And I
of
don't
the
think at this stage you could
Sorry,
go
go on.
deep at all. Oh, go on. No.
Sorry, go, Lisa. Go.
No, so I was just saying, so basically, if I've understood this correctly, so basically his rectus spinae are going to be tight because of the sort of forward tilt. And then also it's going to put the iliopsoas, like the hip flexors, under pressure as well. So they're going to be tight. And then, like you're saying about the abdominals are going to be weak. And what else? And the glutes are going to be weak as well. So I guess you're going to want to take the pressure off the tight areas. So hopefully he's been able to do some stretching, maybe if he's feeling a bit better before he comes to you. And then so you're going to do some manipulation work, but you're going to be led by him because you're going to just work slowly down towards a point where he's really feeling it. As Sarah said, whether things have been firing and stuff, and just be led by that. And I think, like you said, it's down to the individual because you're not going to know really how much he's going to be able to tolerate before you slowly, warm up the muscles and just see what's happening. And then further down the road, obviously, if he can actually start getting back to a more normal pelvic tilt and try to strengthen the abs, and the glutes and stuff, then that's going to help him going forward anyway. So hopefully less chance of, as Sarah was saying, and other people that, of ending up back on the couch again. Obviously, he'd have to come once a month for maintenance work once he's fixed, obviously. But, but yeah, I think it's slowly, isn't it? Because, different people might. My sister, obviously the only person I can treat in a support bubble with her, did her back in, just overdoing it. And on anti-inflammatories and sort of slow stretching and stuff for a few days. But, well, I kind of guess, but basically I think it's like the whole piriformis syndrome, where it gets so tight and starts, causing a lower back pain. And I was a bit worried because she was still in, a little bit of pain, but releasing off the glutes, she said she felt so much better even 24 hours later. Because I was a bit like, you're always a bit like, oh God, you're not going to make it worse, but there's always that thought of. So yeah, that was, I don't know. It's kind of good to know, isn't it, really?
What are we being asked here? We're asked to anticipate what you might find. I think that's how I read that. Which muscles would you expect to find tight and shortened? What are you expecting to find? How will you adapt your palpation skills in relation to the pain he's feeling? I mean, obviously, he's in a lot of pain. You're going to go carefully with your hands, yeah? I mean, anybody want to add anything to that? What would you be expecting to find? Tightness? Yeah, okay. But what pattern of that might be around in relation to where the pain is? What happens to muscles that are in spasm and tight? And what happens to muscles that are opposing? So let's look at those antagonists and synergists. Have that word in our head about those muscles that work opposites.
Well, the muscles surrounding the painful area, they're going to be, Sarah mentioned with the spasm, they're going to be tightening and protecting that area.
Maybe. Yeah, I agree. But say a bit more, Mark. What's the relationship between our glutes and our lower back diagonally? Is there a relationship between your right bum and your left QL spinae? Is there a relationship there diagonally that might give us a clue to what's going on? Would you expect everything, if you're in spasm somewhere and tightness around this lower back? I'm thinking anatomically, either multifidads or deep into that spine as kind of hollow. It could be lats. It could be quite regular, good hands up would be QL. And if it is QL, what would you expect to happen? This is somebody who's in a chronic place, He's been sitting there in this position. It's a bomb waiting to go off. That wasn't quite what you said, Sarah, but you know, something. It's something that's waiting to happen. What could we anticipate how it might palpate? You know,
It's going to be, so if it's
think?
QL,
Or
it's going to
you
be
think-
sore. If it's QL, it's potentially going to be a very sore point one side or the other, like a trigger point,
Could be, yeah.
potentially.
Yeah. I think it's useful. The reason I bring it in, I'm staying on it for a bit because I think it's interesting. Obviously, our range of movement would give us a good clue, wouldn't it, in terms of flexion, extension, rotation, side flexion. Is going to give us a good indication of where the spasm and how tight that road, you know, that whole kind of holding of the lower back is. Can he bend forward? Can he extend? Can he rotate? Can he go side flexion? Some of it will be a lot easier than the other, won't it? By definition here, we know.
Yeah, palpation wise, the lower back, the erector spinae, you'd be able to, you could feel the difference. There's hardly any, there isn't even any give to the skin sometimes when a muscle's in spasm, and you can feel the difference, almost like you can feel fascial tightness in some areas and the others. You'll know that which area is in spasm, and that person will generally come in bending forward because it's a natural instinct to try and get away from the pain, keep yourself in some sort of posture that is going to allow you to move forward or move around. And with the lower back injury, pushing the back into extension and shortening down those injured fibres aggravates them. So people tend to lean forward and they'll come in stooped over usually. So in terms of what you might find, obviously if you're leaning forward, you'll have an anterior tilt, and that weakens the glutes down. Your glutes will be antagonists, not synergists. Yeah, sorry, I have to think of the lingo. And that whole back line will be very weak. That's what I would find, apart from, and you would find that very tight, small section in the back that's in spasm, and it would be kind of recognizable almost. You get to know what you know, normal tissue feels like, what tight tissue feels like, and then what tissue in spasm feels like.
Sarah, would you include the hamstrings in that as well?
In what, sorry, Mark, the treatment?
No, in terms of it all being down you talked about being down about that posterior chain, so the glutes and into the hamstrings as well.
Yeah, because if there's an anterior tilt, the hamstrings are lengthened because the ischium is higher where they attach to, and because they're lengthened, they're not going to have as much power, you know, to work, because they have to adapt from being lengthened to suddenly being shortened. And,
so they're in that lengthened, weakened position.
Yes, that's it. Exactly. Yeah, and the glutes will be too because of that. And we're talking about this guy in particular. We're not talking about general postural, what you might find, because this guy will come in with he'll be bent forward, looking like an old man, unfortunately.
Yeah, I mean, I sort of was going down that route in terms of like the weakened glutes and the hamstrings as well with tight hip flexors. I didn't initially thought that he might be kind of like bent over, but yeah, it's interesting what you said.
Okay.
Chris, do you think he'd be that bad?
Yeah, I liken the tissue palpation to cooked chicken and raw chicken. So if you think of palpating a piece of chicken that's just come out of your oven, that's gone cold, and that feels what that feels like, to a piece of raw chicken that you haven't cooked yet, the raw chicken will be how it should feel. And a bit of cooked chicken that's gone cold is just hard and doesn't want to move. And the whole fascial layers are locked up and in that protective, you know, locked on position. Yeah, very much.
That's like the steak. How would you like your steak cooked? Do you know that one?
Yeah.
Where you put your feet, this is finger and thumb, this is raw. So if you press your pad here, that's a raw steak. And then if you press your small finger, and you can work through from medium rare, medium, well done is finger and thumb together.
Chris, you'll have to find a vegan analogy for that.
Yeah.
Yeah.
Chicken.
I did overcook my chickpeas recently, and so I buy them and I soak them and I put them in a pressure cooker. And
It's the opposite way around for chickpeas, though. They get softer as they cook, don't they? Not the other, not like the steak.
Yeah, and I forgot to put the timer on the pressure cooker, so they came out quite soft. Anyway, so I think what's also interesting for me, this kind of position, is the compensation of how long they've had this. And if it's a kind of the camel straw that broke the camel's back, that kind of thing, then you're going to get, let's just run the scenario quickly. Let's just say that Jack has damaged his right side lower back. Let's pick that. You would anticipate there would be something diagonally somewhere that's compensating, helping him to walk as he is. He won't walk naturally and nice and upright. He will have a stoop and maybe some rotation of how he's compensating and coping with the discomfort. So that whole kind of shoulder, there could be a protraction and rotation of the shoulder. And I think the glutes will be doing something as well to just help hold the situation for him in that kind of protective kind of, and I think to notice some of that. I like the phrase notice. I like when he's bending or moving and you're sitting behind him watching what's going on for him in those range of movement, noticing and what are you being drawn to. And I bring that in a lot, and I think it's really nice to allow yourself to go, do you know, that right knee doesn't look, somehow that bends more and his leg turns out. Not that you're going to do that right there and then, but you notice it for future treatments in how long has he taken to get to the point where, you know, the last straw, as it were, you know. So I think it's really, really helpful. Really helpful to just tease out these things, isn't it? Play around with them.
Another really interesting thing to notice, like you were talking, Chris, about just watching your client come in and how they're carrying themselves. Some people will be bent over in excruciating pain, and they'll come in mumbling along and saying, "Oh, come on, let's get this sorted. I've got to get back to work tomorrow," you know. And then you'll get someone else come in with exactly the same injury. And they'll come in and they'll be like, "Oh my God, where do you want me to go? I can't," you know. So look at the person as well, and you know, go with. Sometimes you have to take on the mothering role or the fathering role for it, and notice what kind of person they are, and then you can work out how you're going to go forward and deal with them. Okay, not with the treatment, I just mean how you're going to behave with them. That's what I mean.
But pull yourself together, man, for God's sake. Something like that.
I'm gonna have
man
to...
up, is that another expression? Do we still use that phrase, man up? Is that a good one?
Get a grip.
Get a grip, yeah.
Get a grip, come on.
I've got to go now, sorry. Quiz.
So lovely to see you. Lovely to see you.
All the oldies.
Bye.
Yeah, I'll see you again. I'll be back.
Yeah, nice to see you. So you take care.
Bye.
Right, okay, so during the posture assessment, which muscles are expecting to be tight and shortened, and what muscles are weakness and do you expect? So are we getting there with that? So you've done a posture assessment. Let's work on lower back. What muscles do you expect to be tight or shortened? Have we got a hypothesis in our heads? I think, Mark, did you mention hip flexors? I think you did, Sarah, Lisa, too. That kind of.
Yeah.
Should we? I wonder if we should just remind ourselves of our hip flexors. I know that we know them, but I think I'm aware, Joanna, you're here, and I've got Ali as well in the background. I think it'll be lovely just to quickly run over some of that basic anatomy stuff, and it's really useful. Never were, always good to just remind ourselves of some of this stuff. So here's our chappie again, and I'll start taking off some of his layers here to get through allows me to get onto his so here are psoas major and minor. Psoas major and iliacus are two main hip flexors. Our belly button is here, so it gives you an idea where that sits in terms of our abdominal wall and stuff through here, deep in our abdomen, really close to our spine, and very close to QL, quadratus lumborum, the muscle we're suggesting that he may well have damaged. Really intimate relationship between these two muscles. If I run the slide for hip flexors, then this just gives us a little quick video of the hip flexors, which is always useful to just to go through. What I like about the trail guide more than any is that the list of the muscles you get with a trail guide gives you the sort of the list of strengthening of these muscles, which is just really helpful, I think. And I say this every time I talk about hip flexors. Obviously, the one that's firing here, psoas, is strong, and iliacus that sits in this just on the inside of our ilium, very strong hip flexors. Interestingly, the TFL here is our third strongest hip flexor, and connects into our IT band. And I think it's really important to remember that when we talk about tight, short IT bands, short hip flexors, very important to engage and make sure that we do a good range of movement test for TFL. And then after that, interestingly, we got sartorius, and then down the list we got rec fem. And people just get a bit confused about that. When you talk about hip flexors, people generally just work on rec fem or see that as the most easiest muscle to see in our. And so important to develop skills here to work on these deeper muscles in the abdominal wall, and not shy away from working on those, because you've got to work through and around the abdominal wall and deal with, particularly area and, working on there's a really nice technique of coming in round here by the ASIS, and just drop into here, which is a nice way of getting across to these two here, and and not shy away from that. That working on these muscles is absolutely essential for Jack, and our MET for level 4 students is your golden tool, I think, for working on these. Okay, so I hope that's helpful. It's always helpful, isn't it, just to remind ourselves of the hip flexors. When we talk about hip flexors, what do we mean? They're the 4 that I teach in the classroom. There's others, abductors, and Doug Magnus and anterior fibers do, and other bits, pectoris does. But I think it's just helpful to learn those 4 and really get our heads around when we talk about tight hip flexors, which ones are we talking about? They do. Anybody want to add anything to that, or the working with them, or the hand skills with them, or thoughts about that?
Is this when the spasms have gone? Are we saying that the spasms have gone or not?
I think, well, I don't know. I suppose my thought would be, would I do any deeper work on his hip flexors and stuff while his spasms were still very present? I probably would. I wouldn't. I would tread very carefully around that. Let's work on the idea that his spasm is better. He's not needing to guard it as much as he was, but he's still in a level of discomfort, and life is not normal. How about that? Is that a reasonable place to sort of measure? It is hard to guess, isn't it? What do you do, Mark? What would your thoughts be on this one?
What, in terms of treating him with spasm?
No,
yeah, I mean, I agree.
That judgment of when do we say to Jack, come in and let me have a look and see if we can start to get some slow fascial change in this anterior tilting, so we
I
can
think
start to hollow out.
If
Go
he was still in a bit of discomfort but not spasming, I think that's okay to start to do a little bit of work. If he's still spasming, then no, I wouldn't be doing any soft tissue stuff. I think it doesn't have to be completely pain-free. I think if he's still in a little bit of discomfort, that's fine. But we obviously work within his own pain threshold as well.
Yeah. Yeah. And you know, that whole kind of judging how much to work on stuff, I think is a real kind of you know, suck it and see. You know, it's a real kind of how much do you stretch out and do some work on the spinine group around the Q area.
Yeah, I mean, it's really, really important not to chase the pain here and overwork the area as well. You know, you can do work around the surrounding muscles to kind of desensitize the tissue even further. You don't need to focus on, again, you know, it's that whole chasing the pain thing.
I think I would be pretty, I don't know what you think, Sarah or Lisa. I would be fairly driven by my range of movement. If the hip flexors were really kind of shortened and I got a very positive Thomas test and a very kind of taking his heel to his bottom, if rec bend was really kind of obviously very fixed, then that would give me a fairly good brief to start working. What do you think? I don't know. Hard, isn't it? Hard to judge.
Yeah, you can always pop a couple of pillows under the back to support the lordosis. Makes things more comfortable for a client to lie on their back, so that you can get to work on the anterior tilt. Because if that is detrimental to his recovery, it's got to be addressed first, hasn't it? You know, if the lordosis is going to continue to hold those lower back muscles short, this is going to be something that reoccurs.
I completely agree.
Yeah.
In the same way as I think. Sorry, Sarah. Go on. I interrupted.
Only you've got to start the work on the hip flexors first.
Yeah. There's always the argument here about strengthening and lengthening, and yeah, at what point, if at all, does he need to strengthen his glutes, or are his glutes not working because his tight hip flexors? So actually, by working on his hip flexors and getting some length and movement back into his hip flexors, all four of the ones I've shown, would by definition start the glutes to start firing again. So are the glutes weak, or are they just switched off? And that kind of, I'm not sure about switched off. Are they just not able to work at the moment because the opposite muscles are over dominant? And that would be my hypothesis for this.
Once you've worked on the hip flexors, you could then do testing for the glutes and see what the strength of them is like, and you know, then you would know whether it was the tight hip flexors that were affecting the glutes, or whether the glutes actually do need strengthening.
Sure. Yeah. Yeah. So your sense, Sarah, will be, let's start with these hip flexors. Yeah. Let's start the anterior, trying to shift the anterior tilt of the pelvis and get some. And now, I suppose with level 4 and 5 above, MET is your golden tool here in terms of being able to engage these muscles and get them to release. And would you agree?
Yeah, I do like, I mean, every therapist has got their faves, their favourite moves. I'm sure you just get into a habit of them sometimes, don't you? But one of my favourite moves is actually STR on the ilium, which I think you suggested, Chris, where you tuck your hands up and over the top of the pelvis and you get the client to bend the knee. And then if you're working on psoas, the heel stays on the couch and they drop the knee slowly down to a straight leg So they're stretching out that hip flexor. And if it's ilium, it's better if the foot is just so far off the table or as the leg straightens. So that's one of my favourites, because that really makes quite an impact quite quickly.
Yeah, no, I agree. I like favourites, sir. I like favourites. That's good.
Well, we've all got, you get into habits, don't you? You can't, sometimes they're hard to shift, but some of the good ones stick. And
you know, I think that's one of the nice things about our Thursday nights, that you can come along and just watch somebody work, and they do something, and you think, I haven't done that for ages, or you know, maybe I could just steal that idea and go home and play with it and adapt it and make it yours, you know, and that's what's so we don't see enough of other therapists working, do we, to be able to share our skills in a way that is kind of supportive and not stealing. and it's so nice. It's so nice and lovely to see other people work and enjoy that, you know, for what it is. So Thursday nights are great for that, and I'm hopeful that come after Easter, when we get back to our therapy working, we can open up Thursday nights back in the building, which will be great. Are we happy with the muscles that are weakened? I think we kind of, Mark, you mentioned that, abdominals and glutes. You know, it's that classic lower cross syndrome, you know, where you've got the pelvis anteriorly tilted, lordosis, hip flexors that are tight, hamstrings, I think you said it well, that locked long position weakness, and abdominals, that core stability. I think for me, I have a vision. I'll bring my hands up so you can see what I mean. I have a vision between the pelvic floor and the diaphragm needing to be on top of each other. And the moment the pelvic, I can't do it with my hands, but the moment the pelvic floor tilts or the diaphragm gets pulled one way or the other, and the relationship between these two become imbalanced, you end up with a problem. Particularly for, this would be useful for you, Hannah, post-pregnancy and post-babies. You know, the relationship here as your abdominal wall starts to take shape again. But that abdominal kind of pelvic tilting and the diaphragm over the top, it should sit all nice and square and balanced. And if we lose that, then we end up with this core that we talk about all the time being out of balance. And then we get that mix of abdominal stuff and glutes being out of alignment. And I guess we're looking at, you know, what kind of, we'll go on to it, I'm sure, in terms of rehabilitation exercises and stuff for this guy to start to think about. So how do you suggest any tight structures could be stretched? Oh, there we are, I'm on there now. Or lengthened, bearing in mind that many joints and his muscles cross. How could you stretch? Could be controversial introduction or consideration to Jack's pain he is experiencing. Yeah, so how would you ease him out of this situation? Our treatment would be working on hip flexors, trying to ease out his anterior tilt of his pelvis, and maybe doing a bit of work around the target area where the pain is, lengthening stuff a bit there to see what happens. Yeah, would that be a reasonable place? What do you think? Yep. Add any bits to that?
No, I think that's about right. I think that's about right, because like Sarah said, if he's in so much pain, and obviously, you know, that if you're sort of easing off the hip flexors, then hopefully then the lordosis will ease off a little bit, you know what I mean? It'd be less pain anyway to then start working on erector spinae and things like that, and testing QL and other things, depending on what, you know, the postural assessment kicked out. But yeah, and then sort of slowly though. So I guess, you know, in between sessions, he could go away and do something really, you know, when he is able to sort of lay on his back without support, like a pillow or whatever, underneath his lower back, he could literally just try and ease that pelvis back into a better position, almost go the other way. So just sort of gently lying on his back with his knees up, take a bit of pressure off, but trying to just literally, you know, push his lower back down a little bit and start, you know, trying to use the core to do that, you know, just slowly. But it's, yeah, and obviously if it hurts, stop, don't do it, leave it. But yeah, slowly, I think, isn't it? And you know, similar, like, it depends how much pain his knees in, I suppose, as well, for like lunges and things, for the, you know, stretch the hip flexors and stuff at the front. Yeah, it's going to be sort of led by, it's almost, if he might not be up to doing anything after the first session, but if he then comes back, you know, the following week or whatever, and he's been, you know, and he says, actually it's eased off a little bit, I've managed to do some of the stretching, you can actually sort of see how he's doing on the stretching. Obviously make sure he's doing it right, and judge for yourself really as well, and see, because like Sarah was saying as well, some people mask the pain and go, oh yeah, no, it's all right. You can tell by their face that it's clearly not all right at all. Or other people, you know, got maybe a different type of pain threshold, and the slightest thing is gonna trouble them, maybe disproportionately to, you know, what you're looking at. So it's important to see them, I think, doing the stretching as well. But obviously not going to be able to do that in between sessions particularly. Just want to do it on Skype, I suppose, if they're a bit unsure, and go through it. But yeah, it's slowly, isn't it? Because everyone's different, I guess. But just starting to try and correct things a little bit.
One good thing that he could do, and this wouldn't involve stretching, is to actually roll the muscles with a roller bar. So you're getting the length and the increased blood flow into the muscle, but you're not asking him to stretch. So the back's not being aggravated.
Yeah, like that.
You know, so you could just use, you know, it's like a bar, and it's got rings that roll around, and you literally just rolling pin those main hip flexors, rec fem. If you can get into your adductors, great, but you could definitely do TFL, and you could definitely do the quads with that. I sometimes teach my client to do their own STR with the ilium as well, because it'll, you know, it's good for them just to keep increasing the length of it. Yeah, it depends on the pain. I mean, I would be, if he can lie on his back, so let's say we're a few weeks down the line and we're still working with him and he can lie on his back comfortably now, I would actually use the Thomas test position to do METs and STRs. So have him lying on his back, bringing one knee up to the chest, and then obviously you'll see the deficit of the anterior tilt, but then you can get them to flex the long leg up into you at the hip. You know, you can put pressure down on the thigh as they're trying to flex the hip. Do your counting, relax, because you only want them to have a leg flat. They don't need to be hanging off the end of the bench to get extra extension, not yet, maybe later, but not yet. So that's how I would probably start him off with METs that way.
Yeah.
And if you can manage that, you should be able to manage STR as well on the edge of the couch. So if you have one leg hanging off, you can do adductors or rec fem, can't you, that way?
Yeah. I'm a couple of ways. My thinking about this is there's twofold really. One is people know that I like referral stuff. So if you know a good personal trainer or rehab or a good physiotherapists are very good at rehab. That's what they do, and you know, it's not. And for this guy, I wonder if there's some, you know, okay, so he's gone into spasm. There's nothing untoward going on in terms of disc dysfunction, but somehow I wonder whether or not there is a place for some joint mobilization and thinking about his SI joint, and just I would want him to get that kind of thing kind of looked at and sort of you know, seen So I would. Hi, hello.
Hi,
Hi.
sorry, I was putting the kids to bed. Hi, I'm Asako. I'm so sorry I'm late.
No, it's lovely to see you. Thank you for joining us. We're what are we doing? We're mopping up at the end of somebody who's got a bad back, and trying to understand, trying to suggest things for him to do. So you're very welcome, and it's nice to see your face. It's nice to see faces generally, isn't it? I'm getting mildly.
Are you Chris?
I am Chris. On a good day, I'm Chris. Tonight, it's okay. I'm on Chris. Nice to meet you. We're about to talk, actually. I will make contact with you in the next couple of days and say hello to you, spend some time with you. But yeah, I'm Chris. Nice to meet you.
Chris, I've got to go. I'm really sorry. I've got dinner waiting. So
Have you?
Yeah.
Oh, right.
Yes.
Nice to see you, Sarah. Look after yourself.
So sorry, guys, but yeah, I look forward to seeing you next week. Have a good week, everyone.
See you, Sarah. Thanks.
Bye.
Bye.
So, you know, I like that model of thinking about referral, and I like that, you know, here's somebody with lower back, here's somebody who's, you know, we're starting that journey of opening up their lower backs and getting movement back in for them. And I think it's really interesting to think, well, who else is there out there, you know, be that Pilates or yoga or other kind of disciplines that you could, you know, plug these people into for that controlled rehabilitation. And I'm a good believer in that, and I've built up some good relationships with personal trainers over the years who can help with me with thinking about this stuff. One of the exercises I would get this Jack to do would be laying flat on his back with his knees bent, and then engaging his core stability, his tummy, and starting to get some rotation in his pelvis, and just try and make that move a natural, gentle one, not a jerky kind of quick moving thing. So there's a sense of control of lordosis and anterior and posterior rotation of his pelvis while he's got his knees bent.
So he's on his back with his knees bent, and he's then just moving his knees from side to side.
No, his legs are straight. So he's just got his feet on the ground, his knees are bent, and he's rocking his pelvis.
Oh, okay. So anteriorly, posteriorly.
Yeah.
Okay.
Yeah. So therefore, I would encourage him to do more posterior tilting than anterior tilting, because that's obviously anterior tilting is which is the cause of the whole problem.
Yeah.
So we don't want to encourage that particularly, but it's more about engaging the core, our tummies, and getting control of the movement, and getting movement, particularly his abdominals, to start to engage and add some stability.
It's also just getting him in that position where he can feel that, where he feels like he has control. He knows,
yeah, true, Mark.
Okay, I'm going into an anterior tilt, I'm going into a posterior tilt, and just getting that, just getting that feel of his own body and these different positions. But I agree with you about the referrals as well. I mean, I like that. I think we're okay to offer gentle stretches and maybe some other kind of exercises, but essentially, if he needs to strengthen some of his core, his abdominals, then that's probably the work for a personal trainer and some work in the gym.
Yeah, I just think there's limited stuff that we can do in the treatment room. There is stuff, and there is stuff to do, but I think sometimes actually to get people into a routine of doing, asking somebody to do their work at home can be quite tricky. They forget and this, that, and the other. But if they know they're going to go to a gym or go to a physio, they've got a framework and a structure that helps them rehabilitate. And I think that's, for me, that's been my experience. But hey, we've got those skills, Mark.
It was my experience as well. When I had some issues, I was going to see a physio, and he was giving me exercise and stretches. And at some point, when things were kind of improving, but they were almost plateauing a little bit, and he said, right, I'm now going to refer you to a PT that I work with, and this was going into a proper gym, and we did all the strength tests. So, I mean, that was the exact process that had happened to me, and it worked well.
Yeah, I know, but again, that certain clients, if you suggest that, they haven't got time for any of that. This is very much a personal judgment, isn't it, of how we kind of measure people and work out what fits for them, and other people just want you to come up with some stretches and examples, and off they go. They're beta away at home and do their stuff. You know, we're all different. We're all different.
Yeah.
Also, I've discovered, Chris, my local physio, who I go and see for my own treatment when bits fall off, well, not completely, just, you know, if you refer somebody for the first time, you get £5 off your treatment. So all jokes aside, it's worth, if you build up a bit of a relationship through, you know, your own injuries and treatments or whatever, local physio, because then at some point, hopefully they can put people your way. Well, I've done all I need to with you. It's less likely to work that way, but I didn't realise this, and because I rated them, I sent a lot of people over there, and I was quite far into doing that before somebody said, "Oh, did you get them to fill out a referral form?" And I went, "No, I didn't know you had any." But yeah, so they sometimes have schemes anyway that can actually benefit you a bit. So just thought I'd pass that on, because I've been referring people for months, and yeah, I had no idea about this.
Yeah, no, it's a nice model, Lisa, and yeah, and my relationships are being two-way, you know. So later on, a PT sends somebody my way, you know, and a soft tissue work. That's what we do. That's what we're good at. Personal trainers don't know much about that, and so, you know, it's a really nice reciprocal. Is that the right word? Reciprocal kind of relationship that can be beneficial on all sorts of ways. Yeah. So carrying on back with our case study, Mr. Jack. We're on to the last couple of bits really. So how do we suggest we tighten structures? Could the stretching or lengthening? I think we kind of played around with it, bearing in mind that many joints and muscles. Yeah. How could stretching be introduced in? Because I think we're kind of got that fairly in our heads in terms of working with pain and judgment and not overdoing it. Yep. And how can this be stepped in relation to reduce it? Yeah, I think any bits anybody wants to add to any of that, or I think we're there with that one really. I think it's all about, you know, the combination of answers we've come to really. And the crunch for me is, go on, sorry, Lisa.
I just asked, you know, the knee flexion, what would have caused that given everything else? Because I couldn't quite work it out. And the only thing I could think of was because the hip flexors are so tight, that's why it was a little bit bent when he was stood up. Is there a particular reason that you know, like a definite link or a sort of causology that, because I couldn't quite, do you know what I mean? I guessed, but what would be the answer to that, do you think?
Are you expecting me to have the answer?
Yes, I am, Chris. Well, no, some ideas, because the only thing I could think of, you know, unless I don't know anything about golf, but unless, you know, if it was his right knee, say, and then he's going through for the swing, and then that was I don't know, bending or whatever, and then putting something out.
I'm kind of, yeah, I'm probably in a not a dissimilar place to you, so Lisa, than thinking about it really. I'm suspecting that his knee flexion is more to do with how he copes with the anterior tilt. Mark is standing up, bobbing up and down. I don't know what he's up to, but Mark, I don't really want to know, Mark, but if you're standing upright, Mark, and you flex your knees, what happens to your pelvis?
Flex my knee.
I
can't really feel what my if I'm being honest.
Oh my God, Mark hasn't got a pelvis.
Yeah. If he did, I think we're going slightly potty, aren't we, tonight?
I've been going potty for a while. It's lockdown, isn't it?
My sense of it, Lisa, would be a guarding thing, where we tend to, if we flex our knees, it tends to show that maybe our anterior tilting, or we're guarding, or we're stooping slightly.
Yeah, okay.
And it's more of a habit of protecting our lower back, I guess. But
it could be what Sarah was talking about, you know, with the guarding and leaning forward. Because when I was reading through it, I was kind of like, oh, that slight knee flexion, what's that related to? You know, okay, so you've got your quads which extend the knee, you've got your hamstrings which kind of flex the knee. So is it something to do with that? But yeah, maybe it was that, or maybe it was a bit of a red herring that was just thrown in there.
Is this the guy that drives a lot?
Yes.
It could be
Yes.
getting out, how they get out of the car also. Could it have
Yeah, that's a good point, Asker. Yeah. Could it will be something like that, won't it? His common posture of, as you say, getting in and out of a car, or how he sits, or
Sometimes these guys put wallets in the back of the back pocket, and it sits in the car like that. Or do they tend to take it off? I think they tend to leave it in there, so they sit slightly tilted too. That can affect.
yeah.
That's a good point. I never would have thought of that, actually.
Do
Yeah.
you know, one of the points I've made in COVID is that I don't use my wallet at all now. Not that I ever really did, but I don't go out with any. I don't go out now anyway, but I don't go out with any cash. I've got no car. I just take my phone, and everything's on my phone.
Really?
Life
Yeah.
has
You got
changed.
the Apple Pay thing then, Chris?
Yeah, but it's just
I'm scared in
I'll
case I
be-
lose my phone to do that.
Yeah, I'm with you on that one, Lisa, as well. I like
Yeah.
the pay sort of things. If I lose my phone, then I can't do anything.
Yeah, you're completely stumped, aren't you? Yeah.
Anyway, right. Sorry. I'm not sure this is related to Jack at all. It's not really, is it? But anyway, right. So this is a crunch question for me, and I think it's really nice for us to spend a bit of time playing with. When would you recommend Jack returns to his golf, and what measures can you take? What measures can he take to prevent further flare-ups in the future? So the first bit is, when would you recommend Jack returns to golf?
I would say when he's corrected his tilt and got more strength in the areas that are weak, so to give himself a chance. Because if he goes back, and his position sitting, then because it's a bit like when weightlifters or whatever doing squats, if the hip is out, that will then kill their back and stuff, won't it, going straight back into it. So he needs to correct almost, not bad habits, but I guess, but try and correct the posture as much as he can, I think, before he goes back. So like you were saying about the PT, I'd want him to work with a PT to get to a point where a PT made that decision and said, right, you've now got enough strength, you can probably, or a physio, you can go back to normal activity. Because I don't think I'd be the best judge of that. And also, I think, like you were saying as well, you're more likely to get into a proper routine if you've got another professional involved, because he'll just be thinking, oh, well, if it goes again, I'll just go back to the massage therapist. Rather than looking at the, sorry, go on, Mark.
Sorry, no, go on, Lisa.
No, that's it, really. Yeah.
Yeah, I mean, good point. So, I mean, one thing is, he going back to the details about him, was that he was playing a lot of golf. Was he just doing, after not doing much activity and doing too much sitting, that 3 days of golf, was that almost like too much too soon? And it was just overdoing it. It's probably playing round after round after round, day after day. Which means that could he return to golf essentially when he's pain free, whilst he's still working on the anterior tilt and strengthening and stuff, just maybe not overdoing it, maybe just playing a one round of golf,
or just doing the putting rather than the whole flipping swing,
or just
like crazy golf or something, just little gentle.
Jack's got a very important tournament coming up in 3 weeks' time, and he can't miss it. He's been waiting to play this tournament forever. You can't just take his golf away from him. I mean, come on, let's be serious. He's, come on, this is his lifeblood. This is the reason why he gets out of bed in the morning. You can't imagine that you're going to take golf away from him. So you're suggesting,
maybe just
wait, how long that been, Lisa? 3 months?
Go on, no, but I just say, well, go and practice some putting first of all, see how you get on.
Practice some putting.
A bit of crazy golf, keep himself occupied, keep his skills up.
You give him the exercise. He's doing the rehab. He's doing the exercises. He wants to play in this tournament. So you say, right, you can start the tournament, but be guided by your pain. If it starts to hurt, then pull out of the tournament.
Yeah, that's fair one.
So what's
a warm-up massage?
Yeah.
Sorry, say that again. Sorry.
Have a warm-up massage and cool
Ah,
down.
there's a good point.
Yeah.
Your place.
I'd be his personal massage therapist. I'll go with him on the golf course. He can pay me.
I like that idea. So you could set up a little gazebo on sort of, I don't know, are there 9 holes in golf? Sort of after about 3 holes, he's got a little gazebo where he gets a little pit stop, hot drink, and a bit of a white. It's a fantastic idea.
Yeah.
It's quite repetitive, isn't it, golf?
It's what? Sorry.
Still quite repetitive, golfing.
Yeah.
One-sided swinging.
Yeah. Well, yeah.
Yeah, it's pretty damn boring as well, I think.
You get to walk around a lot, though, I hear.
If anybody sees this, we're recording this evening, so if anybody watches this, and my arrogant view of golf will be, he was seeing a nice guy, but no way am I going to go and do any work at that academy. He doesn't like golf. Brilliant. I think it's fantastic. I just ruined my whole.
Nice guy, but not much of a golfer.
Yeah.
Yeah.
Oh dear. Right.
Maybe we could pick a different sport every week and slate all of them.
Yeah, we could work our way around. I've got another one for next week. We're on. Don't worry. I'm on. So, so he's got to be reasonably pain free. Yeah, that's where and range of movement has got to be okay.
Yeah.
Yeah. He's got to be working on stability and working through his core stability and lengthening his hip flexors. And then we're going to allow him to putt a bit, a little bit of, what was your expression, Lisa? It wasn't
Bit of crazy golf. Bit of crazy golf.
Crazy. He's allowed to have a warm-up crazy golf. He needs to go to the seaside somewhere and get a little.
I think he needs to do something to offset all the driving and being in that sitting position all the time as well. Not just for golf, but just for for his general health and mobility and flexibility. So if he can have some kind of stretching and mobility routine that kind of, as I said, offsets the driving, I think that will help going forwards.
I've had an idea about that, Mark. What about the Pope mobile, where the Pope stands up and waves? Can you actually drive while you're doing that? Do you think? I appear to have been cut off, Chris. I don't what. Hello?
Yeah. Now, if we're going to get religious, that's it. I have to mute you from there on in, Lisa. I know what you like. Once you get some idea in your head.
Sorry. You've got a lot of editing to do, Hannah.
I have. Poor Hannah's going to be, I can't say that, and language has been acceptable up to now, so we've got to be very careful. Okay, so I think we're there, aren't we? I think we've exhausted Jack. I think he's done a good job. And I think that combination, isn't it? Some soft tissue work with us doing our stuff, working on releasing those hip flexors and keeping that kind of anterior tilt of the pelvis, trying to reduce that, flatten out his lordosis, core stability work, referring off if needing to do that, and he's got a kind of sorry.
Would you recommend 3 times a week session with us for a soft tissue massage?
Probably, I think possibly 3 times a week might be. It's always a difficult this, isn't it? How much do we want them to come and see us? How much do we want them to be rehabilitating themselves?
Right.
And that, there's a danger of the whole responsibility being with us, and we want to encourage this client to become self-sufficient. So how do we kind of get to a place where this guy is managing himself so we are made redundant? And I think that's always my goal. I want to be to the point where I see you 2 or 3 times a year. But to start with, you usually, a general kind of game sort of set thing, I guess, is that you would leave 5 to 7 days between our treatments.
Really?
So, when we're going in and we're doing our deep tissue work and we're softening tissue and we're creating fascial change, that whole linkage under the skin, the tissue needs time to repair and adjust to what we're doing to it. And everybody's different, and I think it depends a little bit on if you're dealing with a fairly advanced athlete, then twice a week might be perfect. But if you're dealing with somebody like this guy who sits on his backside, drives all the time, plays golf at the weekend, to go and see him that often would probably create quite a lot of bruising and soreness in his skin. Not because we're working hard, but because the tissue is just not used to it.
Yeah.
Does that make sense? So I would say initially every 5 to 7 days, something like that. If I was seeing this guy, I would probably do some work with him and then leave him to do a bit of relaxing, stretching, see him again in a week, something like that, 10 days, and then see and measure that and just see, is that okay? We can always bring it forward, we can extend it. I like that model where it's a lot of discussion going on about, negotiating and thinking about what's right for him and his back. And also, the reality of money. If you're charging 40, 50 pounds a treatment, then I think it's helpful to be open and honest about that with people. And, if you're seeing somebody 2 or 3 times a month, that's quite a lot of money. And to be thinking about that with people, I think is important, or to have that discussion as something that is, open and up for discussion. Anybody want to add any bits to that? Lisa, do you want to add times to that, or Mark? Mark's back. Any other bits that anybody wants to add to that? Or Gemma, I'm aware that you're sitting there scribbling away, and Ali, I guess that you're there too, scribbling away. Useful tonight. You're new to us in terms of very early days of understanding our language and our subject, but lovely to have you.
I find it fascinating, to be honest. It's nice because I'm getting used to all the words and the terms and it wasn't completely over my head, so that was good. There were bits, but there were bits that I'm sure that in time it will come. So no, I did find it very good, very helpful.
It's just helpful to be in a place where you can hear the subject being talked about and start to feel these new words and this language we've got to try and understand about how the body works. And so it's great.
Are you just starting a course at the academy then?
I'm just starting the level 3 sports massage, so I'm going on the 8th.
Oh, hi.
Hi.
On 8th.
Yes.
Brilliant. Well, I think joining these Thursdays, and then also when you can go actually to the Thursdays that are being held at the academy in person, seeing people work, I think really helps. It really helps with the learning of the course.
I really can't wait. Been looking forward to it for ages.
Whereabouts are you, Laska? Where's home?
Hereford, so it's going to be a little while. I might be a little bit late, but I'll try my best to be there on time.
Yeah, there's when we open again on Thursdays, it's from 6 to 9, and there's no kind of beginning or end. You just drop in at any point. So if you arrive at 7 or 8, it doesn't matter. It really doesn't matter. There isn't a start and finish. It's very much a drop in. But we'll talk about that. You'll get some information when you come and join us. And I'm hoping to kick those off again after Easter, after the 12th. That's the plan.
Is that you talking about session like tonight?
No, tonight goes on every Thursday night up till then. While we're not able to go into the academy on Thursday evenings, we've set up this evening. And so they're here every Thursday, but that runs from 7 to 9 on Zooming, like we are now. But once we are back in the building, as it were, and we're able to do Thursday nights in person, then that starts at 6.
Oh, is that available to us as well?
Yep, very much so. But I won't be Zooming, and I can't do both. So there's a bit of discussion to go on about that, and I can see Hannah looking at me here, and I'm looking at her looking for guidance. There's some discussion to go on about that. We have done some Zoom work in the evenings, and we tried that, and I'm not sure, a little bit not sure if that works. But the idea for me is to get back into the building so people can come in and drop in. Obviously, due to COVID and the whole kind of PPEing and social distancing, we have to limit the amount of people in our building at any one time. But there's some work to do on that in the background, and I might bring in somebody else so that we can have 2 rooms going. At the moment in the academy, we can have 8 people in each room. And it's, you know, we might have 2 rooms going.
Evening session will be very difficult for me, actually. So Zoom will be perfect.
Yeah.
To carry on.
It's a complex subject and difficult to, like everything, it's difficult to please everyone and to get it right for everyone. But we're still in that place of kind of discussion. I might do it alternately, I might do different things. But the other thing to say, just while you're there, is to make sure that you join the Tuesday night Zoom support sessions for people doing level 3 and level 4, but they're alternate Tuesdays. But probably good for you and I to spend a bit of time talking ourselves, just you and I, and maybe we can find time tomorrow, whenever, over the next few days, to have a little think about that, and I can introduce a little bit more about the Tuesday night support groups for level 3.
Fantastic.
And that's every fortnight.
Okay.
While you're doing that,
the 5 full days.
Sorry?
I'm definitely coming in for the 5 full days. That's I've arranged the childcare and everything. So
when are you doing that course with us?
Sorry?
When are you doing that course with us?
8th, starting on the 8th.
8th of March.
Yeah, the Tuesday, Monday, Tuesday, and Sunday, Monday, Tuesday.
Yeah, get that. Okay. Probably good that we have a conversation with each other over the next couple of days. But let's arrange that outside this meeting.
Yes, sorry.
Great. No, it's lovely to have you here. Nice to see your face. So thank you for jumping in and joining us. It's just really nice.
Ali, are you doing the level 3 as well?
Yeah, I'm going to be doing the level 3 starting on the 8th as well.
Oh. So the 3 of you are going to be there. That's rather nice, isn't it, to meet people before you're going to do it?
Yeah.
Brilliant.
Are you as well, Mark? Is it Mark? Yes.
Yeah.
I did the level 3. I've done my level 4 as well.
Oh, I see. Are you coming back to do it?
Yeah, I just enjoy coming to the Thursdays.
Oh, I see.
trying to learn as much as I can.
It's very interesting. Even the last hour, but thank you.
Yeah. The concept of Thursday evenings is all about coming together. It doesn't matter if you're a student, doesn't matter. Mark and Lisa qualified at bits, they're doing their thing. It really doesn't matter. The idea being that it's about just coming together and thinking and sharing. And tonight we've gone through a case study. Next Thursday we'll do the same from 7 to 9. I'll post up another case study that is just talking through, if you had a client that was like this, Jack, this guy who's playing golf, how would you think about it? What would you do? How would you do these things? And we did one last week and it was quite fun. And today has been the same.
But it is good though. I would say it doesn't matter what level you're at, whether you're just starting out or whether, like, you know, Mark's a whole course ahead of me, but we learn from each other anyway. You know, every time you do these drop-in sessions, you learn something new or something you didn't know. So it's really beneficial anyway to everybody, I think. I certainly find it, because when Sarah was talking earlier, I've only just got the books to start to look through for level 4. So certain things like the muscle energy techniques and the other stuff, whatever it is, I don't know about yet. So it's good to hear about that and kind of start putting it together in your head. So
Lisa, you need to come and join me on Tuesday this week from 6 to 7, don't you?
Yes, I have to say, because I was on late last week, so this is my first opportunity to now start. I've got the books, I'm starting to look through the books, so Yeah, for the level 4, is that next Tuesday, this coming Tuesday?
Yes.
Yes. Okay, that's cool.
Is that right, Hannah?
I'll look it up. If not, Chris, it's fine. I'll look it up.
I think it is. I think it is.
I'll check. I'll check.
I do one level 4 one week and a level 3
Yeah.
the other week. And up to
I'll
now,
check.
I've been trying to keep it in my head. I'm
Yeah.
pretty sure that this Tuesday coming is level 4.
I'll check, Chris. Don't worry. Do I
It
need
is.
to have started doing the online stuff to
No,
join it?
Doesn't
Okay,
matter.
cool. I might have.
Doesn't
Yeah,
matter.
I might have a chance.
Join to doesn't matter where you are. I'll go
Okay.
through whatever you want to do. So if you come along and you just ask a question about, look, on this tutorial, I'm not sure about this slide, we can talk about it.
Yeah. Okay. Cool.
All right. So it really doesn't matter. And what you'll find is that everybody's at slightly different places, and
Yeah.
it's more of a Q&A type thing.
Sure.
And it can be, if you want me to, I can get into screen sharing and dropping in some, whatever you want to talk about. So
Yeah.
you certainly won't leave the evening unclassic. It'll help you to think about.
Okay. Cool. Julia.
I think we've finished with Jack, so I'm going to say goodbye to the recording. So let me just turn that off.